And these are my disclosures. And on the left-hand side is how Dali views himself in a self-portrait. So this is the patient, 39-year-old woman, coming into your office as a new patient. She complains of a new lesion on her left upper arm. As you remember, these are, again, all computer generated, so you can tell it's not got the physicality of a true picture, but it's pretty good. And clinically diagnosed the lesion on her left upper arm as a congenital nevus. However, when you start taking a history, this is her family history. Melanomas, all those melanomas, including at least 10 to 15 dysplasic nevi, mother with pancreatic cancer, brother with melanoma. So you know you're in the world of hereditary melanoma at this point, all right? So what should you do next? You want to send blood work off for germline testing first? Do you want to send off blood for cancer panel testing? Do you want to refer her over to cancer genetics? Or do you want to do nothing because she's under good surveillance anyway? So actually, it's probably a good idea to get some element of a genetic story about her. So let's move on. This is genetic counselor that she saw. And a couple of things you want to do when you're dealing with genetic counseling. You want to push some information, general knowledge. You got to bust out the double helix a little bit. The patient wants to know about it. Basic tenets of autosomal dominant recessive sort of inheritance. The influence of genes and environment. Just because you have a low risk profile doesn't mean too much sun is a good thing. So you got to understand how the environment plays on that. A sort of brief display of the genes known to influence melanoma risk. The carrier probability is good. The validity of the test is kind of important. Probably the most critical thing is getting your results back and how to explain certain things, especially these things called VUS or variants of unknown significance, and the clinical implications of the test. So these are sort of very basic things if you're going to engage yourself in genetic counseling or if a genetic counselor is doing the job for you. Testing and insurance coverage. They often ask about that too. Basically, it is covered. There's no discrimination. There are laws against discriminating against genetic information. It's been really well vetted through breast cancer, colon cancer genetics. So melanoma is not, again, the most commonly sort of applied genetic, test scenario. You want to pull some information out, namely, why do you want to know your genotype? All right, some of them come in, I got to get genetic tested because everyone in my family has it, but they haven't had melanoma, so how would things change? And what would you change differently? If someone says, hey, if I am CDKN2A normal and at low risk, I'm going to tanning beds every day for the rest of my life. Wrong reason to genetically test your patient. All right, so with this patient, she agrees to genetic counseling, and you refer over to a local counselor. And the custom panel shown up front, often you get 50, 20, 80 genes at once. It used to be about $1,000 for one gene. Now it's much less for 80 genes. In fact, it's really cheap to get your entire genome sequenced. The real question is, what do you do with all the extraneous genes you don't know anything about? So these are the ones commonly associated with cancer. So there are specific recommendations. So she has what's known as a Scottish mutation in CDKN2A. And as you remember, this is hypothetical, created. So allows me to sort of go through some of this. I'll quickly go through because this is the most common mutation you're likely to confront in your practice. What are the functions of the genes? So first, this is a complex pathway, but I've isolated and highlighted the single protein that's important in this pathway, which is CDK4. So the gene is P16ARF, shown there in the gray. And P16 inhibits the CDK4, and that's critical because the CDK4 goes unarrested or unchecked. It phosphorylates a series of proteins, including the retinoblastoma protein, which then triggers cell cycling. So that's why they start getting cancers. The other thing about this gene that's critical is there's a protein called ARF, or P14ARF, and that, in essence, sort of guards the P53 protein, all right? So when CDKN2A is absent, P53, which is the guardian of our whole genome, is destroyed. So in a single mutation, you can create increased birth of cells, and you're diminishing the death of apoptosis, or the death of cells. So because of that, patients with CDKN2A mutations are at increased risk for both pancreatic cancer and melanoma. So how common are these mutations? Well, if you look at familial sort of studies, roughly across the globe, about 40% of patients with a family history have a P16 mutation. All right, now it's different in different regions. If you're in Australia and 3 family members have melanoma, it's because they all went to Bondi Beach together. Not necessarily a P16 mutation, but if you live in Leeds in northern England where the sun never shines, and 3 people in your family that never go outdoors gets melanoma, that's much more genetic in nature. So it depends on the ambient rates of melanoma. And the other thing is, it depends on the family history. If you have a family cluster, there's often other genes that sort of are co-inherited and put you at risk. In a general practice like ours, if you have a single mutation, you have about a 1% chance of having a CDKN2A mutation. If you have multiple primary melanomas, it's about 3%. So those are kind of numbers to take home with you. And what is the likelihood of developing melanoma with a mutation? So that's called penetrance. Shown at the bottom in blue is the lifetime risk based on SEER, all right, which is about 3% at this point. And those are the curves if you have a mutation. I'm just going to sort of highlight the United States. 76% lifetime risk of melanoma if you have a mutation in CDKN2A. This is among families. 95% in Australia if you have a mutation. So the penetrance or the risk is very much elevated compared to the general population risk. All right. So what do? I put them under protocols for high sort of risk patients like FAM. Generally, skin protection and skin checks at home. I often follow them every 3 months to 6 months, depending on their phenotype. And I also refer them to a GI doc for consideration of pancreatic cancer screening, because they are at much greater risk for pancreatic cancer. And of course, you want to discuss genetic testing with the family. Now, remember, genetic disease is a family disease. So someone's first-degree brother, for instance, are also at risk of being a carrier with these mutations. The only problem often is the family dynamic is more dysfunctional than the protein, in which case it's very difficult to get them to say anything. So you're like, did you tell your brother? Did you tell your mom? No, I hate him. I don't want to tell him anything. You kind of got to work through that, all right? And the one thing for sure is if there is a mutation in the family, the non-carriers are at lower risk. However, there's no mutations detectable in the family. You can't say anything because it could be in some gene causing melanoma that we haven't discovered yet, and that person is carrying it. So unless you know the family signature, you can't make an assignment of safe versus unsafe. All right, so different day, hypothetically, different counselor altogether, some other possible genetic outcomes. One is the BAP1 gene, which I'm sure you've heard about at some point. And these are typical lesions you see in the BAP syndrome, which are largely these small, sort of round, often reddish to sort of dusky red papules. They're sort of called cutaneous bapomas technically. They're called BAP1 inactivated melanocytic tumors. In fact, there's probably more names than lesions in a given year, all right? They've been called so many things, but bapomas is a catchy one people use. Often the skin lesions may be the very first thing that a germline BAP1 mutation sees. Early onset basal cells are quite common. In fact, they do look kind of like basal cells, but is clinically, histologically is very different. So if you look at through consortial efforts, all the various cancers that you can get, the most diagnostic tumors are cutaneous bapomas, which again is probably an uncouth term at this point, cutaneous melanomas, renal cell cancers, uveal melanomas, which are huge because they're difficult to catch unless they really go to ophtho, meningiomas, mesotheliomas, and breast and basal cells. So I think of them as the crumb sort of cancers, all right? And if there's a mutation detected, usually skin exams every 3 to 6 months, usually for the cutaneous melanoma risk. They're definitely at risk for uveal melanoma, so I send them over to ophthalmology. I send them over for medical oncology consults, even though there are no really great guidelines on how to manage things like meningiomas, renal cell carcinomas, and mesotheliomas, but it behooves you to probably partner up with someone and get some CAT scans regularly, because those can happen with pretty good intervals. This is another gene that's possible. In fact, this is a polymorphism. It's a polymorphism in the MITF gene, which is microphthalmia. In essence, microphthalmia is a survival gene for melanocytes. And as you know from dermatology, we have one that kills MITF. You get things like Warrenberg. Well, this single change, an amino acid 318, actually sort of makes the protein last longer. And therefore, it's an oncogenic factor. It's not a loss of function, but a gain of function mutation. And what happens is this variant happens in about 0.7% of descendants among European populations. It's generally not seen outside of the European population. Risk is about twofold, which is like the MC1R, but it's not associated with hair color, skin color, or freckling. There is an increased risk in renal cell cancer, about 14-fold, but this is among the families. If you just have a sporadic MITF, it's probably not nearly as high, all right? So what do? Skin exam every 3 to 12 months, depending on the phenotype. Patients that are at risk for renal cell cancer, you can send them over again to urology typically for consultation for renal cell cancer screening. Some of them would do MRIs. And overall, I just want to conclude with the era of the Human Genome Project, you're going to get secondary mutations back. I just had one last week where she went for testing for melanoma and got a BRCA mutation back, all right? It's not uncommon. You can't sort of say, oh, great job, no melanoma gene. They've got a whopping BRCA2 sitting there. You've got to sort of work through those. That's why it is really critical to at least have some center institution that you can refer patients to who know how to contend with these mutations that deal with thyroid, that deal with breast, that deal with brain cancer, colon cancer, because you're going to bump into mutations. Remember, if melanoma risk is about 3% overall lifetime, 3% of BRCA2 mutation carriers will get melanoma. So if they come through melanoma, then you're going to find the BRCA2 mutation and not a melanoma gene. So you have to be able, again, if they come in with tests, to understand the implications of that. A couple of things, it depends on the gene, what you have to do. A BRCA2 mutation is very different than a RET mutation or a PTEN mutation. Make sure the patients want to know and say, listen, if we do find something else, generally it's our protocol to let you know. If they're like, I just don't want to know, you don't want to surprise them. They're in Aruba sitting out there. You get a call from Tao going, hey, you got a BRCA2. It'll ruin any holiday. So make sure they understand what the implications are when they test. And also, generally, the recommendations are you let them know about things that are actionable. This is much more meaningful in a whole exome sequence in which there's tons of mutations and tons of genes, and most of them are non-actionable. And patients often freak out with non-actionable mutations like Huntington's disease gene. If you have a mutation and there's nothing you can do, that's incredibly stressful to live with for 20 more years, all right? So I think it's a tricky area. There's a lot of social and psychological sort of implications of those things. Luckily, in a cancer panel, you're not going to be testing for the Huntington's gene. And again, testing through a genetic counselor, it's much easier at the end of the day because they have access to all these other surgeons and oncologists that can sort of contend with this.